Welcome to the Acupuncture Outsider podcast. My name is Richard Hazel, and in the time it takes for you to commute to or from work, I hope to have shared something of interest about orthopedic acupuncture using motor points, trigger points, myofascial slings, neurofunctional acupuncture, segmental treatments, anything that crosses my mind that seems to be of interest. I hope you'll enjoy it. Hello and welcome to another episode of the Acupuncture Outsider. This is Richard Hazel, and today I wanted to talk a little bit about the superficial peroneal nerve and entrapment of the nerve, of that nerve. It's an interesting thing. I like talking about the stuff that you can't muscle test your way to find. You have to recognize symptoms and you have to palpate. Now, the first thing most doctors are going to think with an issue, a sensory issue like pain or numbness in the low leg, will be that it's radiculopathy. It's going to be related to L5S1. There's probably a sciatica diagnosis. And absolutely, those could be in the patient history. There are cases, though, where surgery for the L5S1 issue that was seen, that was determined to be a problem, did not resolve the low leg pain and even bilateral pain. And there are cases where it was found after surgery that there were entrapments of the superficial peroneal nerve. So let's talk about that. It's more common than people probably think. It's most likely going to be a sports related injury, but not always. Let's talk about the deep peroneal and the superficial peroneal and how they're different. The deep peroneal nerve, when there's an injury of that nerve or an entrapment, you will have a drop foot. So the deep peroneal nerve is mostly motor. There is a bit of sensory between the big toe and the second toe, but mostly the motor function of it is going to be the lifting of the foot, dorsiflexion. And that's not what we're talking about. And I've talked about that before, so I'm not going to go into that right now. The superficial peroneal nerve is motor function and sensory of the low leg and top of the foot. So the motor function of the superficial peroneal nerve is to innervate the peroneus longus and brevis, which evert and plantar flex the foot. I find it interesting because the deep peroneal will dorsiflex, and the superficial peroneal nerve will plantar flex. So it helps the calves. And it everts the foot. So the superficial peroneal nerve can get entrapped near the head of the fibula. That's where I find it a lot. And there may be no motor deficit really. There may be the typical weakness that you find in a tight peroneal muscle, a little weak on eversion. This happens to many, many people. It's not indication of nerve entrapment. But what you'll see when there's a sensory deficit in the low anterior lateral leg, could be like lateral calf area as well. There could be sensory deficit, and most of the top of the foot, the dorsum of the foot, is innervated by the superficial peroneal nerve, the sensory part. So the symptoms that people will have can look like a peroneal strain. It will be, if they have pain, they could have pain below the lateral malleolus into the foot area. Um, and the other pain that they could have would be on plantar flexion, like pressing the gas pedal in the car. They could have pain there. And that is actually a sign that it's more likely a nerve entrapment. When you stretch the nerve by putting the foot into inversion and plantar flexion, and it reproduces their pain, you can suspect an issue with the superficial peroneal nerve, especially the sensory part. So the anterior lateral leg, the sural nerve also gives sensory input from the anterior lateral low leg, but the and some of the sensory innervation of the superficial peroneal nerve is apparently on some people shared by the sural nerve. So there is some overlap, but the differentiating factor will be the dorsum of the foot being numb. That's a sensory deficit from the superficial peroneal nerve. So there could be pain. My experience with cutaneous nerves is that they give a different kind of, more like a burning pain than just pain. However, it's apparently not everyone will have a burning sensation. They could just have pain, especially on something like plantar flexion. And things that make it worse are tight shoes, tight boots, ballet slippers that are tied too tight. Things like that can provoke that sensory nerve pain from the superficial peroneal nerve. So the pathway of that nerve, it goes deep under the peroneus longus and brevis in order to give that motor innervation, and then it's going to branch forward into the anterior lateral leg and into the top of the foot, and it varies on different people. Dr. Trescott's book says anywhere from 1 to 18 centimeters proximal to the lateral malleolus is where the nerve will come out. So Dr. Trescott puts the nerve on a stretch by putting the foot into plantar flexion and inversion, and then starts to palpate all the way from the dorsum of the foot through that anterior to the lateral malleolus area, and then up the leg in very likely what's going to be in front of the peroneus brevis area. You're going to palpate for any kind of sensation. Now, here's the thing. Dr. Trescott really needs to nail it and get very exact location for that entrapment, because that's where she's going to inject a numbing agent. As an acupuncturist, we're thinking more about the muscles themselves and the fascia in the area. So our tools are going to be different. They're going to be acupuncture with electric stimulation in order to reset the tension in the muscle. There is a potential for dry needling of the peroneus longus or brevis, because in my experience, that can be part of the problem, especially if it is an entrapment that was originally started by a lumbar issue causing sciatica. So like the sciatica is resolved, you've resolved any compression in the hip. This is the last thing that stands. In that case, sometimes you do need to dry needle the peroneus longus as well. But many people, you don't need to dry needle. You just need the electric stimulation acupuncture of the peroneus longus and brevis, and the anterior lateral leg muscles like the extensor digitorum longus and the tibialis anterior. I find working with those first, resetting them to a better length and flexibility and reducing any hypertonicity, you're taking pressure off of the sensory nerve. Now, the fascia can be causing some of that irritation that will lead to the sensory nerve entrapment. So I would recommend doing some soft tissue work as well, like an IASTM, instrument assisted soft tissue manipulation. So you get your emollient, and you get your scraper of your choice that you like, and you go very gently all over the anterior lateral part of the leg and the peroneals. I would go all the way down into that sinus tarsi area for acupuncturists. That gallbladder 40 region is an area where the nerve could be entrapped. So you want that's why we're working on those the extensor digitorum longus, because that's going to pass through that area. You might even find some sensitivity in the extensor digitorum brevis or extensor hallucis brevis area anterior to the lateral malleolus. So, of course, consider treating that if necessary, or do your soft tissue work there. The whole goal is to free up the fascia and the muscles to no longer be entrapping the superficial peroneal nerve, and especially the sensory part that causes pain and numbness. Um, I've had very good success in one or two treatments on these cases. I find this is the foot neuropathy that is the easiest to treat. That dorsal numbness, the numbness on the dorsal part of the foot. Um, these are the things that are going to get missed if you're just doing some sort of lumbar um, uh, perfusion, or whatever you want to call it, a treatment that's meant to increase blood circulation by treating the lumbar segments. This is what's not going to get better because the entrapment is distal, and it's the stuff you have to find with your palpation. Um, and once you know this, I think you'll have a lot of good success, like I have for these cases, treating them more as a peripheral nerve entrapment than just a radiculopathy where you're just considering the dermatome. Um, so, and this is once you start treating it successfully, you'll realize how much more common it is than you would have expected. Um, Now, I did originally learn about the pain below the lateral malleolus as as coming from the peroneus longus and brevis from Janet Travell's work, because trigger points in the peroneals can cause that same pain under the lateral malleolus. So, of course, it could be just the tendons of the peroneus longus and brevis that are causing that pain in under the lateral malleolus. And then if it goes more into the dorsum of the foot, then you consider the peroneus tertius. And it's interesting because the three peroneals do not share the same innervation. The longus and brevis have the superficial peroneal nerve, and the tertius is the deep peroneal nerve. The longus and brevis evert and plantar flex, while the tertius um, uh, dorsiflexes. So I just find it interesting that they share a name but not innervation. So consider the tertius as a different muscle that dorsiflexes, and that's a drop foot muscle to consider treating for your drop foot patients. But anyway, I was thinking about this recently, and I thought, I've mentioned it before in other podcasts, but I never really made it the focus of attention. And I think it's worthy of attention because of how easy it is to get a misdiagnosis of this case, of this issue, due to it seeming more like a sciatica complaint. So just consider I think the differentiating factor mostly will be putting the nerve on a stretch, putting the foot into plantar flexion and inversion, and see if that reproduces the problem. Also, just the numbness of the dorsum of the foot, in my experience, is more likely going to be peripheral nerve entrapment by the peroneals. And yes, they may be a sciatica patient, but we can't always blame the spinal segments. The peripheral nerve entrapments are usually a double crush scenario. So that's why there are cases where people had surgery for their L5 issue, and then their legs didn't get better because it's a double crush. It may have originated at an L5S1 lesion, but now it's up to us to use our palpation and figure out where else to treat to alleviate the pain. And you see this a lot, and this is kind of tangent, but you see this on sciatica patients where they have a lot of pain in the peroneus longus area on walking. And if you keep treating it only as sciatica above the knee, you're getting in the hip and the lumbar area, you could be missing important entrapment of the peroneal nerves, the superficial peroneal nerves, which are causing this pain down the side of the leg and sometimes numbness into the anterior lateral leg and top of the foot. Okay, so that's that for today. Have a great day.